Hello, everyone. Welcome. Thank you for joining today. My name is Margot Bradley, and I am a member of the Featured Grants Committee as well as a board member at Together Women Rise. Together Women Rise, as most of you know, supports organizations around the world that advance gender equality and improve the lives of women and girls. Today, we're very excited to introduce our May Featured Grantee, Global Pediatric Alliance. I'm especially happy to introduce this organization and talk about it because as a retired nurse midwife, I am fascinated with programs that support maternal child health and work with midwives from a community. This organization, the Global Pediatric Alliance, is working to improve respectful health care for Indigenous Mayan women in Mexico, particularly in Chiapas, Yucatan, and Quintana Roo. And through that training and strengthening community networks and working with hospitals to promote respectful care, they're ensuring that women can give birth safely and with dignity. So it is my pleasure to introduce Stacey Ramirez, Executive Director. Welcome, Stacey. I'm so happy to meet you. And my first question for you is, can you tell us a little bit about the origins of the organization and perhaps even how you first got involved?
Well, first of all, thank you so much, Margot. It's a pleasure to meet you, and it's an honor to be a grantee of Together Women Rise. Yes, I'll tell you a little bit about myself and then the organization. In the 90s, I worked in Mexico and lived in Mexico. I worked with the women's rights organization, Semillas, which is a sister organization of the Global Fund for Women. And it's focused on empowering women in different ways throughout Mexico. And I worked with some incredibly intelligent and fascinating women, movers and shakers in Mexico. And it really gave me this in-depth view of all the barriers that women are facing for their economic well-being, for their health, for their families. I returned to the U.S. and worked in my career with many gender equity and health equity programs around the world. The last one being a program with the What to Expect Foundation. We received a grant from the Secretary's Office of Global Women's Issues, which no longer exists. And we worked with a maternal health program in Bangladesh and in Liberia. And, at that time, then I really started thinking I'd love to take what I have seen and learned. There are so many common threads throughout the world for maternal health and why women are dying for preventable reasons throughout the world. And I'd love to take it to Latin America because I've lived there. I speak the language, I understand it, especially Mexico, and that's how I came to be the Executive Director of Global Pediatric Alliance. So Global Pediatric Alliance is an organization that works to improve the health and lives of women and children in Latin America and to reduce infant and maternal mortality. The organization began, its origins began when a physician from Kaiser Permanente, who had been an Albert Schweitzer fellow in Uganda and then was volunteering time at a rural health clinic in Guatemala, in the eastern jungles of Guatemala. And he learned of these figures of the importance of the midwife, Indigenous midwife in these communities in rural areas where there are few or no health services, and the community health promoter. And he realized that learning basic techniques, just basic health and first aid and practices, by teaching these to midwives and to health promoters, they can take on a large part of the essential care that communities need, that children need, and that women need. So he started getting his fellow physicians and nurses to volunteer, and they would, every few months, have a trek bring medical equipment down and supplies and do a 3-day journey to get to this clinic. And they would teach the midwives and the health promoters. And the midwives and health promoters would tell them what they wanted to learn, what it is that they needed to learn. And so they developed a curriculum. Then the model changed because they realized that that's not really sustainable to be bringing people from the US down. You really need a presence there. You need to know the communities. You need to speak the language. You need to understand the culture. And you need to have a presence there. So the model changed. And that was like in the late 2000s. So the organization was based in, would go to Mexico, Guatemala, Ecuador, and Nicaragua. In the late 2000s, a group of midwives in Yajalon, Chiapas, southern Mexico, asked the organization to come and teach a course there. The courses are intensive courses. And that is how Global Pediatric Alliance has a presence in Chiapas. So what ended up happening is we opened an office in Chiapas. Now I'm in California, but the rest of the team, 10 people, are in Chiapas and in San Cristobal de las Casas. And we work in many different ways to try and eliminate the barriers that women face with maternal health and maternal-related complications.
It's wonderful. I get so excited when I hear that the midwives, sort of took the reins and said, "This is what we want. We want this from you." Can you give an example of the kinds of skills that the midwives were asking for?
Yes. So I'll give you just a little background of the essential role that midwives play, as you know. In so many Indigenous communities, and I'll just preface it by saying that Chiapas has one of the highest Indigenous populations of Mexico. Mexico is considered a middle-income country. Mm-hmm. Therefore, it does not get a lot of aid that other countries might get. But when you go to the southern countries, we have very high, large Indigenous populations. You have maternal mortality rates that are 2 to 3 times higher than the national rates. And in some places where we work, where 85% of women are giving birth at home, it's even higher. Midwives, they have been doing this work and have been this figure for millennia. What has happened is that the Western healthcare model has looked down on midwives, mm-hmm. especially Indigenous midwives, as not knowing what they're doing and part of the problem. So they've been set aside, and they represent so much more than just midwifery. They're a culture, they're an autonomous health system, but they have been relegated to the sidelines, and this has started to fray that very essential autonomous Indigenous health system. So what they have been asking for as far as skills is they need a little bit of knowledge, elements of Western medicine that can enhance their own knowledge, because again, we consider them to be in the center, play a vital role, and they already have a lot of the skills and knowledge they need. But there are things such as evidence-based prenatal care, neonatal resuscitation, looking for danger signs, high-risk factors, understanding preeclampsia and signs of preeclampsia, hypertension, these kind of things that can happen, and also postpartum care.
Mm-hmm. Mm-hmm. I understand. I can go in so many different, very technical directions here, and I'm going to try not to. But I know that some American midwives have learned a great deal from Mexican midwives, Indigenous midwives, with a lot of interesting procedures in repositioning babies and so forth. I've read a lot about it and know some of my colleagues who have tried various methods that we have learned from them. But technical skills like neonatal resuscitation and having equipment, there's also a lot of work internationally at reducing one of the highest causes of maternal mortality, which is postpartum hemorrhage. And I'm sure that you're providing a great deal of education. It takes like almost nothing to prevent this. And providing medications and the ability to manage and recognize those kinds of things. The one thing that I saw in your grant application that I wanted to talk about a little bit was once women are transferred, and I want to know a little bit about what the transfer system is like, transferred to the hospitals, that they face high levels of what you call, and what we call in the United States as well, obstetric violence, which I think is a term that most of our members are probably not familiar with. Can you talk a little bit about that?
Sure. So obstetric violence it can take many forms. It is violating the rights of women and their rights to health. It can be simply refusing service to women in labor. We have cases of women who've been turned away, who have had their babies in the bathroom, in the parking lot. We've had women who have been refused service because the doctor has looked at them and seen, oh, let me look at your knees if they're crumbled, because Indigenous women tend to give birth on their knees. Then if you've been working with a midwife, you go with her. We're not going to help you, because if anything happens to that baby, it's going to be, it's not going to be our fault. So refusing service, we've had women go to the hospital and the receptionist or the security has told them, take off your shoes. We don't want you to dirty the floor when you come in. Or obstetric violence takes on the form of simply not having someone who speaks their language to explain to them what's happening, not letting them having someone accompany them, such as a midwife or their husband or a sister or a mother, not asking for informed consent for the practices, not explaining what is going to happen to them, or speaking to a male companion instead of the woman herself. Things such as simply closing a door when a woman is being examined, shouting at her, yelling at her, or being silent and not even looking at her. Just it goes in so many different ways, so many different kinds of abuse and procedures that took place that the women didn't consent to. And we've had experiences of a hospital that had a campaign. It was a cervical cancer and breast cancer screening campaign for Indigenous women. The women came. Someone took photos and posted them from the hospital on Facebook saying, we did this campaign, and it had women, it blocked out their breasts, but it had a woman being examined or being examined for the pap smear completely improper. And again, she didn't have any consent that is what she wanted to have on Facebook. So, these kind of things that are happening that are just really unacceptable. And
so I'm going to interrupt for just a moment. I want you to explain. So part of our grant is to help your organization to work with the hospitals, the staff of the hospitals, to provide more culturally competent care. Can you talk a little bit about what so you've made the assessment that these kinds of things are happening. What is it that you're doing that's going to help the situation?
Well, it's true. And talking a little bit more about the obstetric violence, 1 in 3 women in Mexico who give birth at a hospital experience obstetric violence. This is a real problem. What we do, and of course, Indigenous women, they say Indigenous women face triple discrimination. Mm-hmm. One for being a woman, another one for being Indigenous, and another one for being poor. Mm-hmm. So what we do is we go to a hospital or a clinic And we start a whole program. One is we do observations. So we are observing the practices and we're interviewing users. And we're interviewing doctors and nurses. And then we are having respectful maternal care courses with the medical staff. And really our hope is for this to cover all of the staff, from the receptionists and the security guards, who are the first point of entry, to the doctors. So and to the directors of the hospital. We want everyone to be in the course. And we go through the whole course process, and then we have agreements made, collective agreements, individual agreements of how you can improve care. What are the rights women have? People often come out of the schools, they're the residents in the hospitals, they're the interns. They haven't learned really what some of these rights are, universal rights that women have for maternal care. So we work intensely with them. Then we create our conclusions of what can happen to improve care. Of course, the area we can affect the most, we're a small organization, is the interpersonal care and things that the hospital can be fixed immediately. But we want to go higher than that. So we develop an improvement plan with the directors of the hospital that is signed with the idea they're going to start to improve these areas. And then we go back in 6 months to observe again. But again, like I said, there are things that structurally need to be fixed. Women often, when they get to the hospital, if they're not experiencing obstetric violence, they go and there's no gauze or medications or materials, and they need to go and buy the alcohol and the gauze. These are poor women, and they also go an ultrasound. It's not working, or it's understaffed. No one knows how to use that machine. And so they're sending women off for private consultations that they have to pay for. So, they're understaffed. They don't have people who speak the languages. So we want to see interpreters there. We want to see a fully staffed clinic and hospital. We want to see the respectful care going beyond just the interpersonal care. So we're developing relationships with the Ministry of Health and with the supervisors so that, it doesn't stay right here, that it goes further, that there are things that can go further to change the reality of healthcare.
Mm-hmm. This is a huge project, and it's really, you're looking at systems change, not just, sort of the care for individual women. Let's go back a little bit into sort of the home birth situation, where you said, I think it said 85% of the Indigenous women are delivering at home. Is there a special story that you can think of to tell us about maybe how a midwife interacted with the family and with your assistance that maybe made a difference?
Yes, I can give you. Well, we have several examples. Midwives are telling us their stories all the time. We have the experience of giving a neonatal resuscitation course. So we give our workshops go through, we work all year intensely with the midwives, and we do the neonatal resuscitation, and then we do a refresher course because we know that practice is important. Mm-hmm. So we were doing a refresher course. We had given the neonatal resuscitation course a couple of months before, and then we did the refresher course. And when we were doing that, one of the midwives kept looking at the instructor and kept looking. And then finally, after the course, came up and told him, she needed an interpreter because she speaks Celtal, Mayan Celtal. And she's told a story. She told a story of how it had been a very rainy night. These are very rural populations, dirt roads or paths through the through the woods to get to the different houses. She was awakened at 12 o'clock at night. It was raining, and it was the sister of her patient, and she was telling her that the patient was, in labor. So she grabbed her packet of midwifery materials. We supply a lot of the materials to the midwives that we work with. It's a backpack, lantern, umbrella, and went several, different 2 communities beyond, walking in the woods, in the rain, through the hills, to get to this woman's home. In the woman's home, she was there, her family was there, and there was a fire going. So the midwife, Maria, said, she put the towels next to the fire to get them warm. And before she knew it, the woman was giving birth. The baby was born, but she noticed the baby was not breathing. The baby had blue lips. The baby was limp. And there was a panic, silence and a panic. Oftentimes, that's where the story ends. The baby dies. It has become a common thing. A baby is stillborn, it dies. So she had remembered the course and the practice. And so she got the towels and she was frothing the baby in the back and still, turning over, and still the baby was limp. And so then she gave this signal. She did this to tell us that she was doing mouth-to-mouth resuscitation. Mm-hmm. And she did, the first one, still limp. Second one, she was just remembering what she had learned and going through the function. And it was on the 5th breath. Finally, the baby's chest rose and the baby started wriggling and kicking and cried. So she quickly, delivered the placenta, cut the umbilical cord, wrapped the baby, and put the baby on the mother's chest. And she told us later the baby is alive and fine. They went to the doctors for the clinic. The baby is doing fine. So it's those kind of stories that you hear that with a little bit of help, you can save a life. You can do something that before may not have taken place.
Thank you for that story. It is always so remarkable to me how small things can save the lives of mothers and babies. And that kind of repetition and knowing you to develop as a midwife, to develop that muscle memory of what it is that you do requires, sort of really yearly practices and so forth. And it's just so exciting that you're providing all of that. So I did get a little bit of a background, a warning that we're really near the end of it. So the programs so we're going to be supporting both the programs within the hospital as well as midwifery training programs. I'm very excited to support all of that. Is there anything that you'd like to say that we haven't covered already about how you feel our grant is going to help your organization?
Yes. So another really important point of working both with midwives and with health institutions is to bring them together. And bring them together so they understand where each other is coming from and the different ways of care. They know they need each other. And so we, in our programs, we bring the midwives together with the nurses and the doctors to have dialogues. And another really important part is that we work with the Nichichi midwife movement of Chiapas. This is a movement that started about 10 years ago of midwives from all over the state, 650 midwives, rural, mainly indigenous, also urban. And so it's not only getting together for technical reasons, it is getting together to become a platform for advocacy, because midwives work in isolation. They have so many barriers they have. They've been criminalized. They're again, like the fraying of the healthcare systems for them. And then, of course, when something happens, they're the ones that get called on. So they have been going through a lot of leadership training, and we've been supporting them. And they are having meetings at the local level, at the state level, with the Ministry of Health, with the civil registries, because believe it or not, a lot of children are not given their birth certificates if they're delivered by a midwife. So they're advocating to demand that these children have their birth certificates. They're also going to the national level, and they're also going to the international level. They'll be in New York for the United Nations Forum for Permanent Forum for Indigenous Issues in April. And they're advocating at a worldwide level. So we're really proud to support them. So I think it's like these barriers that women face from the household to the institutional level. You need to get them. You need to work with the women in the community, which we're doing, with the midwives, with the health institutions, with the government institutions, to really make real change. And one last thing, I know we're running out of time. I just wanted to thank everyone at Together Women Rise, because this support is so important. Again, when women who often feel like their problems are their own, they live in a world that no one knows, and they realize that women from thousands of miles away who they may never meet are supporting them, it makes all the difference.
That is so wonderful. We are so grateful for the work that you're doing and having this opportunity to partner with you on this project. The members watching, I want to thank all of you for being part of this community, for your donations. You can see what it is that they're doing. And thank you for being part of Together Women Rise and supporting organizations like the Global Pediatric Alliance and other organizations around the world. We really, really appreciate it.